Next, Dr. Ganesh Wadekar, sir.
Good afternoon, respected chairperson, my seniors and my dear friends. I'm Dr. Ganesh Wadekar from Pune. Today I'm here to conclude my work since last 25 years. This is my humble submission to all of you. To start with, this is the true measure of medical progress is not in new techniques alone, but in the timeless principles that guide the application. Since the evolution, we know that Tympanoplasty, since 1954 by Professor Zollner, till today there are various graft materials, different techniques and types and approaches have been tried to improvise the success in Tympanoplasty to achieve this graft closure and the hearing improvement. But to me, I try to find out what is the success. Is it only the graft acceptance or hearing improvement, or it's a short term or long term, it's anatomical or physiological? Just to give a support, this is my work since last 25 years. So whatever technique, whatever thing I have done, it's a mention, just a postural approach I used to do in mostly cases. The graft in primary cases, temporal fascia, in adhesion revision cases, tracheal composite graft. And most important is tympanometal full cup flap elevation with complete depethylization of the drum with vertical meatotomy. And at times is a canalplasty. These are the few steps. Elevation of the flap. And I just want to highlight here, the moment we depethalize, what we see where we are keeping a graft is the graft bed. So elevation of the graft, maintaining the vascularity of the flap, assurance of the graft bed where I am putting a graft bed. This is what I want to highlight here. Vertical meatotomy is just to avoid, if you cut the flap, anterior posterior flap to maintain the vascularity, the flap is anterior based and posterior based. This is a wide canalplasty just to have a 360-degree view of the whole graft bed. Again, I am repeating the graft bed. So the graft placement is done over the fibrous layer, fish out technique, certain total perforation, avoid lateralization and free skin graft in most of the cases. This is how I place the graft. Placement of the graft, if you see the uniformity of the graft, the handling of the graft, placing on the drum graft bed. And this is fascia fish out technique in subtotal or total perforation just to avoid lateralization. This is the core of treatment, and I was very happy for last so many years. I was getting very fantastic results. I used to claim is 99.9% success rate. That was a short-term success. When I came to know it, so this thing came in my mind. So integrating the timeless principles for surgical excellence. So we need to create a concept. What is a concept in Tympanoplasty when we do it? It's a thorough, what it requires is thorough surgical training and experience, patient selection and preoperative assessment, proper size, viable graft, stable graft bed, and technique with respect to pathophysiology of each case. And the most important is post-operative care and follow-up. And these are the things which really matters for short-term success. Is just putting a graft and accepting the graft. That is what we always assume. So infection is the main culprit which spoils everything in success. Otherwise, quality of graft, rest of the things remains to the surgeon. That requires the concept and the skill of the surgeon. And few things remains that of the post-operative care by the patient. So these are the three factors which really matters for short-term success. And after doing this, when I am getting my own patients, when somebody has done the cases, when I am getting this recurrent marriage, that is thinning of drum, reperforation, adhesive drum after cartilage imposition, that has made me to think what is wrong. When I am saying it is, I was claiming 99.9%, then why this is coming? That is trying to go inside what is happening, what must be things. So then what is the success then? The graft maintenance has to be the success in long term. That we call it as a physiological success. So these are the success parameters what I try to mention it. The factors affecting long-term physiological success, what I came to know, is a coexisting sinonasal pathology, congenital cleft palate, and status of the stagion tube dysfunction. And remember, believe me, I have done almost more than 100 or 200 cases of bilateral tympanoplasty, and I have operated these cases after coming for otorrhea, meningitis, SMR with bilateral turbinectomy, SMR with face or bilateral with conchoplasty. A few of them, still 20% of cases still coming for pain and other thing. That has again made me nervous. So they are coming. This is, I'm started predicting the outcomes. Long-standing dry perforation based results, because it is a reversible stagion tube dysfunction. Adhesive drum, adherent drum always gives a better result with cartilage support. This is something what I call is a very standard format. I mean, just mentioning here. Perforation with congenital cleft palate and nasopharyngeal incompetence always inconsistent in poor results, because it is an irreversible stagion tube dysfunction. That will come later. So I have started doing now. This is a very primitive study I am doing now. Stagion tube dysfunction on impedance odometry, that too with the perforation. So that what it gives, there are two types of graph, type A and type B, and in certain case type C. It's a normal tympanometry graph impedance. When we do a time B test, there is a sudden fall in the pressure. So that gives you the irreversible. The type C is the irreversible type of stagion tube dysfunction. So from that we can make out, we can predict whether while operating or any cases, whether stagion tube function is a reversible phase or irreversible phase. So this is how the definition of this stagion tube dysfunction has been categorized. Stagion acute, chronic, reversible and irreversible. Irreversible is the one thing where we cannot have anything. So then I have realized this is the mastermind who really decides the status of the eardrum in long term, is the status of the stagion tube dysfunction and the existing sinonasal pathology when we operate the eardrum repair. It's not a conclusion, it is just a final thing what I just came to understand. So all the cases of perforation chronic reversible stagion dysfunction healed lifetime if surgically well placed. This is a mechanical success what I said. Certain cases in adhesive drum in chronic reversible stagion dysfunction may heal for lifetime with sufficient cartilage support. The mostly cases of adherent adhesive drum and cleft palate in reversible stagion dysfunction will always have a retracted drum or adhesive drum in spite of cartilage support. That we always see after 13 years, 14 years of tympanoplasty or even the cholecystectomy surgery, whatever we place in the mastoid cavity, everything goes inside, everything gets retracted, everything is atrophied. So what is the force which retracts? Always the mandal of Malleus. What is the force which always retracts the posterior superior pouch? What is the force which always makes our ossiculoplasty, what we say, nothing, not a single ossiculoplasty people they are claiming is a very permanent or stable ossicular graft. So these are the things what somebody has told me just now. So dynamic stagion tube function, dynamic medullary function, we should predict how the stagion tube function is happening, the tube is functioning there in the middle ear. So this is what is my message is. Thank you so much. So ultimately this is what I just want to convey. I like to just get a questions from your side, please. Oh, I'm so sorry. So I thought you must be having some questions or some doubts.
You were talking about stagion tube function and all.
Yes, sir.
So only here, tympanometry will give you the everything.
Absolutely. This tympanometry, impedance tympanometry in the perforated eardrum, that is the only test which gives an idea whether the tube is in a reversible phase, whether the tube is in irreversible phase. This is a very few primitive cases I am doing the test. Clinically, see, after doing so many last 25 years, this is one last 2 years or 3 years I am doing this test. Otherwise, what I came to the conclusion, this is a clinical conclusion, why then patient is, why the drum is getting retracted again. In spite of keeping a cartilage, in spite of doing anything, you want to keep n number of techniques. Technique is not important. Graft is not important. Which graft you are taking, how and where you are placing the graft, where you are placing whether the graft is going to stable there. Then beyond that, what I'm thinking, see, in spite of doing repeating, see, the thing is that, sir, when I'm claiming the patient, I'm giving 100% result. And when I am presenting my cases at 99.9% results, so that has made me to think where the things are going wrong. So this is the thing which is always, see, always what I always accept, we have to accept there is always a nature beyond, above us, which is always governing us. The stagnant tube function is the only tube which we don't have any solution till now.
A lot of eustachian tube work is being done worldwide now.
Hmm.
There is special eustachian tube conferences going on. For
Yes.
testing eustachian tube patency or not.
Right.
Because eustachian patency is not just everything.
So it's not a mechanical patency, it's also all physiological. It's all
It
physiological.
is absolutely very well.
It's a physiological function. So what we are dealing with all surgical stagnant tube surgery is all done for only patulous stagnant tube. We hardly bother about the muscles which is acting on the nasopharyngeal end of the stagnant tube. Please.
So according to you, it's only the eustachian tube you are thinking of that there is a vasoretraction.
Absolutely.
What about additives?
See, ultimately the changes, whatever happens in the additus, nothing happens in the additus isolated.
We have a concept of doing a control
Right,
and having a patency.
right,
Why? Because there are two pathways, anterior and posterior path,
right,
for air conduction inside
Right.
the middle.
right.
So anterior will be taken care by the eustachian tube. Posterior has to be with the additive because it's a breathing cavity.
It's true.
So have you got any research regarding that?
See, the thing is that there is certain papers on that. Whatever the changes happen in the mastoid air cells, the changes in the mastoid air cells doesn't happen isolated. Any changes in the middle pressure changes or anything wrong with the middle stagnant tube. It is not an isolated change in the mastoid cavity.
That is what I am asking.
Yes. So I am not in that.
Have you started doing a control hole for all patients?
No, no.
See whether what is helping. A control hole also is helping, or it is only the eustachian tube that you are.
It is the only. See, the thing is that the control load, as you said, we always collapse the cavity. We obliterate the mastoid cavity. When we physically obliterate the mastoid cavity and the.
I'm talking in case of non-mastoid.
Right.
Not done.
Right,
And you have done only a timber.
right,
Those are the cases where there is a retraction according to you.
right.
Done. So there will be a posterior pathway also which will be, more important with your additive and antrum.
The pathway obstruction in the posterior inguinal for whatever additus and antrum, that normally once we close the perforation, whatever the edema, soft tissue edema or granulations are there in the mastoid antrum, that is blocking the antrum and blocking the mastoid, whatever say, everything gets recovered. This is a in a reverse way I'm talking. If yeah,
Another way, regarding the eustachian tube function can be in two ways. One is mechanical, other is physiological.
it's true.
Correct? So what we are looking at by doing a tympanometry is a mechanical function, not a physiological function.
It's a physiological function, sir.
How you are doing a tympanometry.
Right.
It's physical.
Is opening and closing is opening and closing when we say, sir.
By physiology,
Right.
is basically the lining.
Absolutely.
The mucosiliary clearance. That is
True,
what I
true. So that stagnant you are rightly, whatever you are saying is that this is very true. But thing is that physiological function is totally what I said is a chronic congenital cleft palate. These are the cases of physiological. When you say the muscle is not acting properly on the end, on the nasopharyngeal end, then naturally this thing will not happen. And whatever the physiological mucociliary clearance or blockage, whatever is saying, that is altogether different. That is taken care by the medication therapy or conservative line of treatment.
Mr. Wadekar,
Yes.
is it possible for any autologist to claim the result as 100%?
Yes, sir. I'm very sure that is the thing what I'm saying. When we say it's 100%, infection is the only element which really dissolves the drum. Otherwise, if you really see the physiology property of the temporal fascia, we keep it, sir. Normally, we say there is an anterior remnant.
Worldwide, with the best of the houses, they are not claim 100% result. They are coming up to 94, 95, or maybe their revision cases increasing the number of success rate, and 100% result claiming. I think it will be a.
So, see, it is no. So it's not a suicidal, sir. It's the thing is it is a mechanical. When we think about placing a graft and making cutis, there is see if you take out that infection part. You tell me if you are harvesting a proper graft. One person harvesting graft at different times you cannot harvest the same quality of graft. The problem is here, we never think so we never claim or blame others, yourself.
See, we are student of same teacher.
Yes, sir.
Right, I also got Dr. Tapan. But let me be very frank with you. I think nobody should claim the 100% result. First thing, so many times while doing surgery, you feel that you have done such a fantastic work. And after some days, patient goes with a small pinpoint perforation or some discharge. So how can you claim that? I think
So sir, when we say it's 100%, it's true. No, it's not something, you're not getting my point. It's 100% means, see, the thing is, it's a mechanical job.
I don't want to contradict.
So the thing is that why the perforation is there, you should reveal why the perforation is there. It is my faulty technique. What I said, it's a concept creation and the skill of the surgeon. So hardly we should give some claim to this. So what you can blame someone else rather than blaming patients.
As you rightly said, here those don't, they are connected so well to each other. So we really don't know the cost many times. Why it failed.
Sir, let's
No,
please
we
stick
must
to the
not.
time. There
Thank
are
you so much.
other
Thank you so much.
speakers also.
Thank you.
Thank you. Thank you.
I would request Dr. Prafula Sakre sir to hand over the certificate to Dr. Wadekar sir. Sir.